They also talk about the types of activities which is best, what kind of groups of muscles should you be working on, the methods of such activities, and what are the groups of muscles which are required typically for people to maintain their functions when it comes to aerobic fitness or your general fitness characteristics. The question comes after you go through that, many a times it comes as to what are the kind of exercises which you require to do or to work on as we age. So if you look at it that way, from an evidence perspective, most of the time we see for elderly, we are focusing a little bit extra on this area called the neuromotor exercises, which are to do with balance, coordination, agility, gait, proprioception, etc. So you're looking at three domains: flexibility, strength, and balance, because they're connections, and how best you can enhance them by designing programs which are focusing on these areas. Now I want to bring in one more thing here, which I always talk to in my geriatric preempt talks, is there is something called ICOP, Integrated Care for Older People, by the WHO. Very nice thing to look at if you're interested to read about how to enhance intrinsic capacities, what does the evidence says, and what is the consortium of health professionals who work together in the WHO say. I'm not detailing again. I would just urge you to go and read the ICOP guidelines. It's all about, as I told you earlier, WHO had two things: intrinsic capacity and functional abilities. So they're looking at that. And second is to look at the comorbidities, which come typically as what we call as geriatric syndromes. And then, of course, it doesn't stop at the patient, it also extends to the caregiver, because many times we forget that in the community, at least in India, because they are largely community living, who are the people involved in their care? So they also need to be supported. So that part also is addressed by the WHO's ICOP guidelines. I'm skipping this, it's available free in the WHO publications. So among this, what we looked for working on evidence perspective is to look at this multifactorial interventions. So I told you one was preventive, and second one is, of course, how do we intervene and what direction do we have? So we looked at evidence and we found out that the quality of evidence is low, the strength of recommendation is conditional. So it doesn't make anything great to pick up something and do. So that means there is a role which you have to play in designing things for your population by picking up what you can get as rudimentary things from literature. I'm going to skip this. This also. Okay. Now what do we mean by the so-called multimodal interventions? We are typically talking about a combination of different types of exercises which involves aerobic, resistance, flexibility and balance. I told you the initial thing which our focus was from WHO's perspectives on that. And the emphasis on the muscle groups as what they had talked about and performed in what we call as a functional manner. I'm going to skip this. I've already told you about this. So our idea is to see how we can get this information and adapt them to our populations. So remember, there is a big difference between adapting things and adopting things. Adopting is many a times not at all sensible when it comes to population-based differences. So there are much variables, there are many confounders which may alter the way your rehab works in geriatrics, and unless you look at them, it's difficult. So it's always better to think of adapting. Now that's what we have a responsibility as institutions, as researchers, as students, as faculty. We have the responsibility to do these adaptations in whatever little way we can. So I want to just share a few things as to what we have experienced. I had details of text, but I'm not going to get into all that. But let me just list out a couple of things. So the three things which we are looking at, or three domains which we are looking at when we are designing such things, is to look at the biological, psychological, and social aspects of it separately. Now, each of these things can be used to formulate and design studies in your own little efforts. You can take up small pilot studies, small cohort studies, small comparative studies, any design. We'll talk about it later. So all these things could be taken individually as variables. Some of the things which I have been working on over these years is to look at these domains. We looked separately at community living versus institutionalized people. We looked at people who are sedentary versus active. We looked at working versus retired. So look at the variables which you can bring in. You can look at the socio-economic status individually as a dependent variable, levels of education, because we have evidences on each of them, but we need to adapt them to our populations. And then, of course, the very important thing, motivation, because as I told you, many a times they retire from life. It's not just retiring from work. So we don't want that. So, I mean, we may have to consider that. So how do we apply, how do we connect this evidence to practice? It's actually a journey. You can't think it's, okay, fine, there's a ready-made answer out there. All we require is to look at peer-reviewed index journals with high impact factor. None of those things matter. They help you design something, they help you focus on your interests, but not to create an evidence for you. There is no one has created an evidence and kept there ready for you to read and apply, which is the biggest mistake most of us think when we go to conferences. Okay, we'll get something there and we'll apply them. That's not how it works. You have to individually participate in things, and then you have to be adapting things. We all know this. It is lonely at the top, correct? It's a small place to sit if you're right sitting on top, because if you've gone through all this exercise, you will understand. So we look at evidence in a pyramidal model with the base, which is of very basic things, including so-called expert opinions. If I come here and say that I've got this many years of experience working with this and this is what I feel is right, I'm still down there at the lowermost aspect of this pyramid. If I have to climb up there, I have to participate in what we call as evidence building exercise. And that exercise is what all of us, for the rest of your life, is expected to do. So it's all about connecting these. Look at the things there. It's clinical expertise, best research evidence, and of course, never to forget your patient's values and preferences. I like to use the word patient there. If you look at most of the Western literature, you will find client there. In India, when we hear client, we get wrong ideas. So please don't mistake me for it. So I still like to use the word patients. So it's like this. When you look at evidence, this is what you should be looking at as. One is that, okay, fine, you should have a questioning ability which comes into your mind. As a researcher, as a science student, as a health science student, your first thing is that inquisitiveness. That inquisitiveness will lead you to find things and adapt to things. But as always, it depends. If you want to do something, whether you do it or not is up to you. We know this. Now, how to ask questions? You can't simply go stand in your some circle there and ask some questions. You have to know how to ask questions, and you have to know how to find their solutions. There's no point of simply asking questions. So if you're asking questions and the direction to it, what we call as a research hypothesis, research question, then you've got a methodology, then you've got a plan, then you've got some solid backups which you have. So if you look at research, it all boils around these things. The first thing, of course, is how you ask and design your questions. And then, of course, you've got study designs. You know it, I'm not elaborating. You have to have the right design for the right question. If you have a question which is directed towards X, and if your design is for Y, you don't meet anywhere. You literally are stranded. let me just show you, I know you can't read this very well, but for people, for entry-level learners like undergraduate students who are listening to me, some things can be, made interesting. See, if you look at research as a Herculean task, very difficult thing to do and all, it may not be so easy. You can even look at things like this. This is an example where there's a CSM meeting which happens every other year. I don't know how many years. I guess it's in the US. So they've got the contemporary research articles will all be there together for you. You know what's the in thing now. It's like when you look at what is the current fashion, what should I buy? So if you look at these CSM meetings, they're quite good, but take it only for that. Take it only to know what is in fashion. Don't believe whatever you see, because these are people who have worked on in their limited potentials, and they've published things because their situation in disseminating is much better than our country, that's all. Believe me, the resources which you have is much more than many of these papers. The only difference is we don't publish. So articles like this, this is actually from the latest journal from I think the Journal of Geriatrics. I think it is, where's the journal's name? Geriatric Rehabilitation, I'm sure it is that one, yeah. So, if you look at these articles, it should not, mislead you. Most of the time what happens for a novice researcher is, they look at some evidence, they think this is the truth. And then they start seeing, it's like this, when you go and attend a workshop, you start doing that for every patient. You think that, okay, for example, if you undergo a workshop on taping, any condition which comes to you, you start putting tapes. Now, same thing happens for a researcher. So it should not happen this way. It should not be that you take articles on their face value. You must read in detail what exactly is the methodology, what is the methodological quality of that study, and what is the level of evidence which is brought about by the paper. Now, levels of evidence all of us know, from 1 to 4. In that pyramid which you saw there, the lowest one comes in 4 and highest one comes in 1A. I'm not detailing anything, but please understand, even when you hear the word research report, original article, okay, it's not that you're simply going to follow it as it is. You should know what exactly it says and what is the methodological quality of that study. A couple of more examples, and I just wanted to bring in that the new lookout in geriatrics is to look at some predictors. And among these predictors, the cardiopulmonary markers have been described recently as good predictors for geriatric health and well-being. So a couple of these articles are available. This is, I told you, from the Geriatric Journal. You can find them in most of your databases. But please remember how to read them. That's what I wanted to bring in here. And then, of course, you will also find, protocols, like some of the protocols which have been designed by some particular people. They may have vested interests. They may have conflicts of interest, which they deny every time. But then, if you read things in detail and if you find out what is so different about many of these protocols, at the end of it, you might still start questioning yourself. So my point is, by reading evidence, it is not that you're getting a ready-made answer. You are only getting a direction to your search. So nothing prepares you better than available evidence, but it is not that the available evidence is the end of it. And most of the time, they need to be adapted. So it boils down to this. It may be that you can start blindly believing things, or you can always start thinking the evidence is incomplete. I think the second part of it, even though the image looks the person looks very crooked, there's is a very slow-looking person, correct? People who critic and say that I don't want to follow this evidence is slow. That's what it says, but that's not what it should be. Ideally, everyone, I feel, as a good researcher, should look at things with only a new perspective, and the available evidence should be only a eye-opener for you. Yeah, the exercises which we went through is what I wanted to share with you, but I'm going to skip these slides and I'm just going to come to the findings of that. I'm not really going to explain each of them due to want of time. So I will just tell you what areas of evidence search we have done and what kind of findings did we find in our limited small studies, which I still feel has opened our eyes towards understanding things a little better. Yeah, I'll just summarize them. See, I told you there are certain things which we were interested in. One was about balance, one was about functional training, and we were looking at their interactions with each other and how exactly they will help in reducing the fall risk. But we found out, that both these things appear to be quite good. It's just that how you like to apply them in practice. The context of your clinical practice may not be feasible or suitable for either of them sometimes. I mean, one of them only may be better for you. So the evidence which we tried to open up appeared to help us in this. We looked at, many a times we talk about cognitive dysfunction, so we all look at MMSE and we categorize people and we say, okay, fine, these people cannot do these exercises because their cognition is poor. But we didn't really find, in available literature also, cognition doesn't seem to be that big a detriment when it comes to their interventions and their efficacies, especially in geriatrics. We looked at areas like sleep quality. We tried to see if sleep quality itself is a big issue there. And it appeared to be an early sign or a cause of functional decline. We also found that in our limited studies. Then we looked at people with diabetes. Elderly, most of them, the comorbidities in them is diabetes and hypertension. And we looked at diabetes. And we found in our little exercise that reduction of central adiposity may help in enhancing functional exercise capacity. So it makes sense to advise people to stay active to the extent of bringing down what we call as a central adiposity. Depression is one more area which we looked at, and in depression we found that it needs to be considered because depression, people who have got a depressed state of mind typically tend to fare poorer when it comes to exercise compliance, when it comes to doing what they're directed to do, and using their own ingenuity and their interest. So their interest itself makes a big difference. So if they have depressed, that's a big issue there. So I'm going to just summarize what I said. Of course, I didn't show you the studies which I detailed, of course, to cut down on the time there. So the essential take home which I want to tell all of you is that we need to build evidence. It is not we need to find evidence. Most of us think that we have to find evidence. Some of us go in search of evidence to conferences. But the evidence which you get in conferences should be only for you to build on that. So please make sure that that's what you do. We need to identify a couple of areas when it comes to, in geriatrics especially, two areas I really feel I can authoritatively say. One is to identify cross-cultural barriers, because what applies to one population in one part of the same geographical area may not apply to another. We have so many variables. We have got so many divisive things among us. Some of them could be politics, some of them could be religion, some of them could be socio-economic status, many of them. And we are a land of plurality. So we definitely need to look at this when we are trying to ape or trying to copy things which is available in literature. And number two is we want to look at the outcomes of preventive as well as interventional outcomes, intervention strategies in the target population. Remember, the target population, what you see, may have some characteristics which are totally different from what is available in literature. So the generalizability of findings is something which you would like to address, and that only you can do. Nobody else can do it. Only you who can work towards that and who can adapt and who can ask questions can get the answers to them. So to end it, I would just want to summarize what I said all throughout. It's all about assessing, it's all about asking. Now, I told you the direction to ask is with getting answers. So once you get those answers, you acquire them, and again, you appraise them. You can't simply say that, okay, I found this, and that's the truth. You may require to appraise them. You may require to critically appraise them. You might require to do some cross-cultural or multi-center trials. You might want to ask your friends who are elsewhere working on the same thing to try and see if these can be looked at for their efficiency, etc. And then finally, think of applying. So if that is what you're doing, then what you do is what we call as evidence-based practice. Otherwise, if you're just following a journal article which says that this is the best thing to do, it may come under what we call as best practice, but it is never evidence-based practice. So try to differentiate between them as you're studying. You have a long way ahead. It's always nice to see promising people, young generation people who will do this, I would say, the circle of life when it comes to search for evidence. So I hope you do this exercise, and then your evidence-based practice is going to be feasible. Thank you very much.
Thank you, Professor Sanjay Samuel, sir. It's a wonderful presentation. As we all know that health is a state of complete physical, mental and social well-being of an individual and not merely the absence of disease. So sir was discussing about the age-related problem, that is physical, cognitive and social components. And sir was talking about the active aging and the successful aging. So one more point to add, sir was discussing about the exercise prescription. When talking about the active aging or active aging, we can talk about active participation. Because of the nuclear family system, because of the urbanization, most of the elderly people are living alone. But instead of living alone, if they are living together with grandchildren, they can involve in activities such as, taking care of their grandchildren, taking them to their school, and doing some small garden works. So they can even modify their lifestyle so that they can lead a, active aging. They can have a successful and active aging life. But because of the fear of overburden, because especially the educated senior population, because of the fear of slavery or overburdening, they are trying to avoid all these family responsibilities, such as taking care of their grandchildren and doing small works in the household. But what will happen is that will increase the bond, family bond. It will be a great psychological support. It will improve the psychological health as well as the physical health. So we have to think about it, how in one side, this wellness industry is booming out. Like that, we have an enormous scope in the geriatric care as well as geriatric rehabilitation also. So sir has given a wonderful outline about this active aging, successful aging, and the exercise. What are the functional disabilities the aging people are having, and what are the exercise prescriptions. And finally, sir was talking about the perspective-based model of patient care to evidence-based model. So thank you, sir, once again for the wonderful presentation.
Good afternoon, everyone. Indeed, it's a fruitful session on evidence-based practice of age-related functional decline. And firstly, sir explored what is aging, what is functional decline, and had an insightful discussion on the economics of a country, how the aging is affecting the economics. And you shared a valuable perspective on exercise prescription of older adult, and you have shared more the evidence-based management. And thank you for the wonderful session, sir.
Thank you. Thank you very much.
Any question from the audience? You can please ask, sir. Okay, thank you, sir.
Thank you very much.
Thank you so much, sir, for this great session. I request the chairpersons to honor our session speaker by handing over the memento. Thank you, chairpersons, for concluding the sessions wonderfully. We invite our principal, Sajeevan sir, to give away the mementos to the chairpersons. Thank you. Now, we are giving a special appreciation award to Dr. Pradap Sugandhara Babu. For that, I request our principal, Dr. Sajeevan T, to give away the award. Thank you, sir. Here is an announcement. The quiz competition will be commencing on venue 2. It will begin by 2:45 p.m. The chess numbers and lot number are distributed at counter 9. I request all the cultural event participants to collect them from counter 9, the registration counter. Thank you.